I wanted to do a quick review of the study guide just to give you something audio just so you can hear it, maybe brings it a little more to life, and kind of go over the things and why they're here. So the first thing is the acronyms. While you can look them up, people usually talk so fast in healthcare, or maybe the patients even use them, where you say, okay, well, we're going to need APAP for their pain, which is N-acetyl para-aminophenol, which is the chemical name of Tylenol. But when you say, well, that's Tylenol, that may be unfamiliar to somebody because you can see that, you know, APAP has nothing to do with Tylenol, but it's the chemical name. Same thing with aspirin. Acetylsalicylic acid doesn't look anything like aspirin, and that might be some source of confusion. IBS versus IBD, irritable bowel syndrome versus inflammatory bowel disease, the disease obviously being the more severe of the two. Therapeutic index, understanding how safe or how unsafe a drug is based on where the safe guidelines are. So you might have a dosage that's very low, and then the toxic, you know, or even deadly dose, if it's close to it, then the therapeutic index is very narrow. But if they're very far away, then it's a wide therapeutic index or a high therapeutic index. You can show them numerically, or you can show them also visually. Peptic ulcer disease also. And again, it just speeds your way through an exam when you have the acronyms down and you really understand them and really know them. In terms of writing out questions, you want to, as you're kind of going through, you want to kind of make questions so that your brain starts thinking through it instead of putting fact, fact, fact. Brains don't remember facts. They remember challenges. They remember things that they had to struggle through. So sometimes I like to just say, well, why don't you just change what the content is into a question? So you could do it in this way. Of effectiveness, safety, and selectivity, which is most important and why? Instead of just saying, okay, effectiveness is important, safety is important, selectivity is important. Make it into a question, and your brain will remember it a little bit better. So effectiveness is the most important, because if it doesn't do anything, then what's the point of taking the medication? And if we look at safety, we would see that, well, you know, chemo drugs, they're not really that safe. Opioids, there's some addiction potential there as well, and there's a safety factor there. So we will use drugs that are not necessarily the safest, but we will expect them to be effective. An example where something is ineffective and something else could work just as well, they've shown that guaifenesin, which is Robitussin or just plain Robitussin, has a similar effectiveness to water. So if someone would just drink plenty of water, someone to take Robitussin, they've shown that those work out to be about the same as an expectorant or something like that, or an expectorant. And then selective but not safe. So we haven't gotten into MAOIs, which are a type of antidepressant like isocarboxacid, brand Nardil. And something like this would, especially if it's combined with some kind of stimulant, something that's going to increase heart rate, these are not necessarily selective for the brain because they also affect the heart. So it's watching out for these types of things. But of the question, effectiveness, safety, and selectivity, the most important is effectiveness, and that's because if it's not effective, it's not going to matter. In terms of remembering dates and things like that, the easiest way to do it is to figure out what the story was behind it. And once you know the story, then you understand why they passed the law. Lawmakers rarely do things, almost always do things because something really bad happened, and they're showing that as a lawmaker, they're taking action, they're being a good public servant. The first one is the 1938 Food, Drug, and Cosmetic Act of 1938. Sulfanilamide was a drug that had actually been out since 1900. It was Bayer who came out with it, and I think it was in Germany at the time. And it came out as a tablet or some kind of oral dosage form. But some chemists wanted to get it into a liquid form. And the solvent, or what they used to get it into that liquid form, was very much like antifreeze and started killing people. So because of that, safety was something that a drug had to be. It had to be safe. It didn't have to be effective yet, but it had to be safe. In 1962, the Harris-Kefauver Amendment, we saw the thalidomide tragedy, which was not in this country, but what happened was there's two isomers that come with thalidomide. One of them helps with anxiety, and one of them unfortunately causes these terrible effects of phocomelia. So when it's a birth defect, when a child is born, they have like seal limbs, so very abbreviated limbs. And this tragedy caused them to pass this 1962 law to say that, well, something has to be effective as well. So we're seeing that safety, effectiveness, these are very important things as we go through. 1970, obviously, the Controlled Substances Act. What preceded 1970 was the 60s, and it was clear that we're going to need in some way to classify how bad something is, if we should make it illegal, if we should not make it illegal. That takes a lot of understanding of the medications. Addictive potential is relatively subjective, but understanding, again, the 60s came before the 70s. That's why we saw the Controlled Substances Act. 1992, the accelerated approval of drugs. So in the late 80s, HIV became something that was relatively widespread, and because of that, we saw that the drugs were coming to market way after the patients would unfortunately expire. So they had to have a way of approving drugs faster to help the patient. So that's where that came from. And again, the idea isn't to memorize all these laws and dates and things like that, but to understand that there's going to be a reason that someone passed an amendment or a law or an act or something like that. With drug trials, you really want to understand kind of what the terminology is, and you could change this into a question to say, could you explain drug trial controls, blinding, randomization, and blinding? I used it twice, in 2 sentences, well, maybe one in a definition, one in an example, and kind of do that for yourself. And as you work through this, as your brain has to do a little bit extra, it's easier to remember. So controls, you want to know that something had an effect. So you want to have a control where let's use the classroom as an example. If you change the way that you teach in one classroom, you want to leave another classroom the same as it was, so that you look at the other classroom and say, okay, well, the grades are such and such, and then the grades have gone up in the classroom, or the grades have gone down in the other classroom, the grades have not changed. But you want to have a control, something that is the baseline of what it would be without the addition, or drug in this case, and then what it would be. Randomization, you don't want to skew your results by picking an honors class to be the one that's the classroom that gets the different study technique. You want to randomize the students, and so that you know that regardless of who it is, the outcome is something because of the change that you made. And then blinding removes bias. So if you had told the physicians or the researchers who got the real drug and who didn't, they would act differently towards the patient. They would act like, oh, wait, that's weird. Why isn't it working? You've got the real stuff. And that helps remove some of the bias. Drug development, preclinical and clinical. So kind of figuring out in the lab what's going on, then figuring out in patients what's going on. Why can't we use those preclinical drugs in a patient? You may hear the news come out before the drug comes out, because we're not sure if it's safe. We're not even sure if it's effective. And what they've done is taken a stratification of all of this and say, okay, well, let's put them into these groups, and by putting them into these testing phases, we can kind of understand where a drug is in the process. So stage 1 is healthy volunteers. We just want to know how it works in the body, what kind of biologic effects, how does metabolism affect it, pharmacokinetics, again, that ADME acronym, ADME, to see how it absorbs, what kind of distribution you get, what kind of metabolism you get, and what kind of excretion you get as well. When we get into 2, that's when we actually use patients, and we want to see if it's therapeutic. Is it working? Do we have the right dosage range? When sulfanilamide came out, they had no idea how much to give or how little to give. Imagine a drug coming out without instructions, because that's what it basically was. Like, oh my gosh, we have this antibiotic that helps cure, these infections, but we don't know how much to give, how much is safe. And effective comes with that 3rd stage, We're really kind of tweaking it and saying, okay, well, if we give this much, then it works, but it really hurts the patient. So can we give a little bit less? And then for afterwards, the patients who've already bought it, we're going to do some kind of post-marketing surveillance to make sure that the drug continues to be safe now that we have it in millions and millions of people. Understanding the difference between generic brand and chemical names, really the focus of the Memorizing Pharmacology series is understanding how the drug names relate to its use and so forth. Just a quick example is acetaminophen. This is a generic name. It's in many ways a shortening of N-acetyl-para-aminophenol, which is the chemical name. That's how we used to do it. We used to get a chemical and then chop it up a little bit to make it a little bit more usable, a little bit more user-friendly. Try to keep it to 4 syllables or less. It's not always possible. But you can see that the acet, amin, O, and phen all come from N-acetyl-para-aminophenol, as does Tylenol. At the end of acetyl, you see tyl, and then again at the end of phenol, you see Tylenol. So you see the same thing. Ibuprofen is one of those ones where we've got like ketoprofen and other drugs with that same stem. And then naproxen doesn't have a stem, but it looks so much like ibuprofen that it's a little bit easier to say, oh, well, maybe that's very similar. And both of them are non-steroidal anti-inflammatory drugs. Pharmacokinetics and pharmacodynamics, so understanding the difference between these two terms. Anytime you term pharmaco before anything, it just means drug. So you could just say drug kinetics, drug dynamics, but it makes it sound a little more like it's in the lab, or it's a little more about therapeutics. Pharmacotherapy is, the drugs as it relates to therapeutic and helping the patient. So understanding the etymology, and etymology is just breaking down the words into its parts. So one is what the body does to the drug, and then what the drugs do to the body is the other one. And let's go into the principles, but it's just understanding that these are very different but very essential understandings of each medication. So the 4 pharmacokinetic principles tend to attach to an organ or tissue. This isn't always 100% true, but it's pretty close. So absorption, generally absorption isn't in the stomach, rather it's in the small intestine, which is much longer. And something like enteric-coated aspirin doesn't absorb in the stomach, rather it's protected from the stomach acid to make it into the small intestine, hoping to cause less of an insult with the stomach. Distribution tends to be through the blood, and if we're talking about a local like lidocaine where the dentist puts in that injection, if you use something like epinephrine, vasoconstrict at the site, then you're going to have much less blood flow, and the lidocaine can stay around a little bit more. So just a little bit of epinephrine makes it so that you don't need quite as much medicine, maybe having less side effects. Metabolism, the liver, and something like warfarin would be a concern, where if you have a change in metabolism and you're going to have less or more warfarin, then you're going to have either subtherapeutic, where you have less of the drug, or you're going to have bleeding, where you have more of the drug. Either way, the metabolism and warfarin are always a very big concern. And then excretion in the kidney. So example, there's certain antidiabetics that cause the sugar to go out in the urine, but then that leads to bacterial infections and so forth. So understanding absorption, distribution, metabolism, and excretion helps us understand better the drug, but usually there's one that's really important with each medication we talk about. So with aspirin, it was the absorption. With lidocaine, the distribution when you're talking about the dental injection. Warfarin, the metabolism, making sure that you're getting the right amount. And then excretion with the antidiabetic, that it may cause those bacterial infections. Understanding enteral versus parenteral. So if you have something that's enteral, it just means that it's going to go through the GI system. These tend to be safer, they tend to be much less expensive, and they're certainly much more convenient just to take a tablet. But something parenteral, it's dangerous because you're giving an IV or you're giving some kind of injection. You can't take it back. Someone could vomit up a tablet, but you can't really do that with IV. It's expensive more because if you're going to put a line in or something like that, maybe it has to be done in a hospital or some kind of clinic, and then it's all more difficult certainly to put an IV in than it is to swallow a pill. So make sure you understand the difference between those two. Generic equivalents. So sometimes with two generic names, you go to one store or another store and you're like, gosh, I feel like my headache goes away with this one, but it doesn't with this one. The active ingredient must stay the same, but the other ingredients don't have to. So one can use a different filler, and that may be a little bit different for you and may affect the rest of the tablet. So with two brands, you may find that one does work better for you. Enteric-coated drug forms, like I mentioned with the aspirin before, if it hurts your stomach, we want to protect that stomach. And then, over the counter, something like Ecotrin, which, if you break down the name, it's enteric-coated aspirin. They just took some of the letters from each of those three terms, and that allows you, if you have some GI issues, generally with aspirin or something like that, it may save you. Half-life. So the example that I like to give is caffeine. So caffeine has a half-life maybe around 6 hours. And if somebody takes caffeine too late, it's like, why am I, wide awake still? Well, the drug breaks down in 6 hours to half of what it was, and then half of what it was again, and then half again. So if we have, X number of half-lives, then we can know, okay, well, how much of the drug is still in the patient's body based on the milligram dosage that we've given them. Narrow versus wide therapeutic range, I mentioned a little bit before, but that therapeutic index, if you have something narrow, that is, if the safe dose is 10 milligrams and the toxic dose is 20 milligrams, or if you accidentally give 2 tablets, that's dangerous. But if it's wide, that is, the safe dose is 10 milligrams and the toxic dose is like 200 milligrams, 20 tablets, then you would certainly be a lot safer. What do we do with narrow therapeutic drugs? We very closely monitor the levels to make sure that they're safe for the patient, and that the levels that they're at, based on other things they're taking, maybe food, maybe drugs, aren't affecting them. Loading dose, the example used to be penicillin, where you would give 2 tablets and then 1 4 times a day for 10 to 14 days. But dentists, I think, have moved away from that penicillin VK. The most common example now is maybe azithromycin, which is a Z-Pak. You would give twice the dose on the first day, and then one dose each day thereafter. So the Z-Pak itself has 2 tablets on the first day, 1 tablet each day thereafter. In the liquid, it would just be twice as much on the first day, a single amount each time thereafter. Maximal efficacy, so what's the largest effect that a drug can produce? There's only so much that a drug can do, and some people will take more pills even though it's just making it more toxic and not really helping them anymore. I understand if you have really bad headache, you're like, oh my gosh, maybe I should take 5 or 6 ibuprofens. But really, there's a point where all the receptors are full, and that's all it can do, and you may need to move to something different. That's different than potency. So potency is the amount of drug to elicit an effect. And the example I like to use is that naproxen 500 milligrams and ibuprofen 800 milligrams do about the same thing. Which one is more potent? Well, with the 500 milligrams, you needed just a little bit less medicine than you did with the ibuprofen. But a patient might think, no, I want the bigger number. I want the 800 milligrams. So potency is just a smaller milligram strength causing a larger effect is more potent. We'll see this when we get to neuro and psych issues, where we'll see that the potency actually talks about side effects as well, as we look at some of the first generation antipsychotics. And we'll see that a 2 milligram dose can do the same thing of one drug of a 100 milligram dose of another drug, and that the side effects are based on that potency. Affinity and intrinsic activity. So this is more of a, when we talk about an attraction, if there's an attraction to a receptor site, that's great, the drug can get there, but that doesn't mean it does anything. So affinity is a fancy way of saying attraction or liking something, and intrinsic activity means something actually happens. So a drug may have an affinity for a receptor and it may get there, but if there's no intrinsic activity, it doesn't do anything. But if there is intrinsic activity, that means that not only did the drug get there, but it did something. Agonist versus antagonist. So an agonist is something that activates a receptor. An antagonist either will prevent a receptor's activation. but that doesn't mean that it can't do anything. So for example, the agonist, if you talk about the beta 2 agonist with breathing and albuterol, which is a very common puffer or inhaler, this will open up the lungs and it activates receptors to do it. But something like a beta blocker will lower heart rate because it's blocking the receptors, the beta 1 receptors in the heart. And we see that they both do good things, but one does it as an agonist and one does it as an antagonist. So it's agonist doesn't mean good, antagonist doesn't mean bad. It's just the situation. So once you understand the situation, you can better understand which is which. Drug interactions like beneficial versus potentiative, deleterious. So if something's beneficial, you could say that naloxone blocks morphine overdose or something like that. So that's beneficial. But if you have aspirin and warfarin, they work together. They're potentiative, and they're bad, deleterious, because you could cause bleeding. And there are reasons to use both. They're a bit more rare, but aspirin usually working on the platelets in the very high speed vessels, and then warfarin in the lower speed veins and so forth. But again, there's a potential for something bad to happen, especially bleeding. Naloxone, which I just mentioned, so the drug interaction, it could block morphine, but that could be beneficial. And then when would you give it? You'd look at a very depressed respiratory rate, especially 8 and under. These are just some terms that you need to know. So allergic reactions, idiosyncratic, iatrogenic, and side effect. So an allergic reaction is an immune response. The body's like, I don't like whatever this is. And so we know that sometimes we might use an antihistamine, and that might help with certain allergies. Idiosyncratic, we're like, idio means we don't know. And it's uncommon response to genetic predisposition for it. So something happened, and we're not exactly sure why it happened, because it doesn't happen that way in most people. And that's what we were a little bit worried about. Iatrogenic, so this is iatrogenic, literally meant disease caused by the doctor, but obviously physicians don't like hearing that, so we say it's disease caused by the drug. Let's blame the drug, not the person giving it. But iatrogenic means that in some way they gave care or medication, and the cause was iatrogenic. Side effect, want to make sure we understand a side effect is something that we're expecting at a therapeutic dose. So the way that Benadryl or diphenhydramine makes you tired is a side effect. Okay, but a toxic effect would be a seizure if you had somebody accidentally ingest an entire box of Benadryl or something like that. So the side effect is going to be at therapeutic doses, but there's something that's happening that we don't necessarily like. QT prolongation, just understand that it's a dangerous heart condition or a dangerous heart side effect. That if you have two different drugs that can prolong the QT, that we want to avoid giving them together. So something like azithromycin, brand Zithromax, and sertraline, which is an antidepressant. So we give these two drugs, and we don't want to give these two drugs actually, but which one do we switch? Which one do we say, no, don't use that one, we'll have to find something else for it? Well, they're probably on sertraline for a long time, and the azithromycin is just meant to be a 5-day course. So we would probably switch the azithromycin because we want to continue them on their antidepressant and give them something as an antibiotic, but maybe something else that's maybe second, third line. Digoxin and low potassium is also an interaction, but how that low potassium happens is usually because of some kind of diuretic. So furosemide, which is brand Lasix, is known for causing diuresis, and it can also cause hypokalemia, or that low potassium. And having that altered electrolyte is very dangerous with something like digoxin. Tachyphylaxis, it's easier to look at the etymology. So tachy means fast, and phylaxis is like a phalanx. Like if you think of all the shields together in that movie 300, you might think of tachycardia. So tachycardia literally means fast heart. Tachyphylaxis means fast defense or rapid protection. So what's happening is that as soon as you dose a medication, the nitrates are especially known for this, the body is putting up its defense very quickly. So tachy means fast, phylaxis means phalanx or quick defense. Peptic ulcer disease treatment. So a lot of times we think, okay, we've got these old treatments, maybe giving some milk to calm stomach upset and things like that. But we found that really changing the meal pattern 5 or 6 times a day, much smaller. So if you eat 3 times a day or even twice a day, to divide it to 6 times, it makes intuitive sense. So if you give a large meal, your body's going to produce a lot of acid. If you give a little meal, then it's going to have a little bit of acid. And if you have a little bit of acid each time, then it's going to be a little easier on the stomach, or certainly ulceration in there. In terms of treatments, though, if we have to treat Helicobacter pylori, that infection that gets into the gut, we would use one acid reducer. We don't need more than one. It'll take care of the acid. But we would need 2 or more antibiotics to avoid resistance and to decrease the adverse effect of each antibiotic individually. Prescription versus OTC of the same drug, so something like polyethylene glycol. There's some other examples, but we want to make sure we know which one we're talking about. So if we're talking about Miralax, we're talking about an over-the-counter, very gentle, laxative type drug. But if we're talking about go lightly, we're talking about bowel prep, where it's going to be they want to be very close to the toilet, nothing lightly about it. It's a gallon jug of medicine that they take, and the gallon jug of water is to make sure that they don't get dehydrated. It causes so much bowel movement. So just understanding that there's going to be prescription over the counter, and you might see the same drug name, but they might be different in terms of what they're for. Knowing in constipation what our drugs are and kind of how to stratify them. So if somebody is going to be taking, I don't know, like an opioid or something like that, then you might want to use docusate sodium, which is a stool softener, instead of getting those hard stools. But if you take that, not just because the pill might be big, but you want them to drink a lot of water because they'll get dehydrated. With Metamucil, it's a little bit different. You're talking about supplementing fiber that they're just not getting in their diet. But in both cases, we're talking about relatively gentle relief. Something like Lactulose, though, will increase the ammonia excretion. So you're talking NH4 plus versus NH3 from your chemistry. And you know from chemistry that when you have a positive ion, it'll go into solution. And then if it goes into solution, it can be taken out through the urine. But Lactulose is for those patients that maybe have cirrhosis and their liver's just not doing enough to get rid of this toxic ammonia in the body. Knowing mechanism of action, adverse effects, as we go through the semester, these are kind of the keys. But something like ondansetron, patient has headache and dizziness. Is that something they should be taking still, even with those side effects? Yeah, nausea is very dehydrating, and especially with chemo, those side effects are minor relative to the very dangerous nausea, vomiting, dehydration that would happen without the medication. Anticholinergic effects, so anti against choline, we're really talking about acetylcholine, and we think of the abduct mnemonic. So anhidrosis, which is when we have less water, blurry vision secondary to dry eyes, dry mouth, or xerostomia because we don't have enough water, urinary retention, so we're holding on to the urine, and that could be an issue for the patient. Constipation, the water gets pulled out of the bowel. So as you're thinking of anticholinergic effects, think dry. And then for the ABDUC, like the anhidrosis, no sweating, and so forth. But the tachycardia, that's kind of like it just happens. So you just have something you have to memorize. But I always think abduct water as my way of remembering anticholinergic effect or anti-acetylcholine effects. A drug example that we see in this is scopolamine, which is transderm scope. So you might see someone with a patch on a cruise, and that's what that medication is. It's for motion sickness. Antidiarrheals versus antibiotic treatment of diarrhea. So understanding that if you have loperamide, which is over the counter, versus giving something like ciprofloxacin or azithromycin by prescription. Why do we do that? How do we make that decision? Well, if you have toxins in the body, you want to let the body expel them. So you wouldn't want to stop the diarrhea necessarily. You would want to treat it and treat the bacteria that's causing it. But if you have some stomach upset and you're not really sure why, but you're pretty sure it's not because of some food or some organism, then loperamide makes a little bit more sense. IBD versus IBS treatment. So first understanding again the acronyms, that inflammatory bowel disease is very different than irritable bowel syndrome. Irritable bowel syndrome, we could maybe give some kind of antidiarrheal. It's certainly not curative. It doesn't, diarrhea is just a symptom. It's not actually a condition. So we just want to know that we're just treating it, and we really want to cure whatever it is that's causing it. Inflammatory bowel disease, we need to use immunosuppressants like infliximab, because there's something going on with the immune system, and we're going to suppress the immune system or that hyperactive response. That's also not curative. And then I don't know why I left this down here, but the 500 versus IBU 800 should actually be up there with potency. Naproxen 500 is more potent than ibuprofen. Is more potent than ibuprofen 800, but they actually do the same thing, because naproxen 500 can do it with fewer milligrams than ibuprofen can. Choosing opiates and opioid tolerance. So understanding that something like morphine, if you have to take a lot of pills, that's a big pill burden on the patient, and maybe using fentanyl would be a better choice. So thinking fentanyl in terms of a patch. That shouldn't be tablet. That's a table that I was referring to. Tolerance is a decreased effect. Pushing the green button on a morphine pump, knowing that as you continue day by day, that morphine will work a little bit less, and you'll need a little bit more medication. Desensitization is when someone becomes immune to a medicine, or they're just it worked before, but now they're kind of desensitized. It just doesn't happen as much. Abortive versus prophylactic treatment of pain and headaches. So either you're stopping a headache that's happening now, abortive, or you're going to prevent a headache from happening in the first place, which is prophylactic. And you want to know that what the parts are of Excedrin migraine. It's really telling in terms of what's going on. So the aspirin is for inflammation, the acetaminophen or the APAP is for pain. And although the aspirin helps for pain, the dose is pretty low. But by using both, you reduce the need for high dosages with both, saving the patient from side effects or lowering them. The caffeine's a little bit interesting. It vasoconstricts the blood vessels in the brain, so it should help a little bit with the headache as well. But I've also heard that it helps increase the metabolism, get the drugs there to the patient better and faster, which is critical in something like a migraine. Triptans, we look at the ending of sumatriptan, and we see Imitrex is the brand name, but understanding that these are for aborting a migraine. If a migraine's happening, a patient needs something like this. And we have to be very careful with hypertensives, because it can cause rapid vasoconstriction, so we want to watch out for that, especially patients that have history of stroke and things like that. TCAs, so a tricyclic antidepressant like amitriptyline, or a beta blocker, which is an antihypertensive, or there's other uses for it like propranolol. These we see for prophylactic treatment. The patients take very low dose each day to prevent the migraine from happening in the first place. But note that you can't always classify a drug as doing something, because tricyclic antidepressant, we're not using it for depression, we're using it for migraine prevention. The beta blocker, I was talking about the actual mechanism of action, but we're not talking about antihypertensive or something that's lowering blood heart rate. We're saying, okay, well, we just know that people that take these on a regular basis at a low dose will have fewer headaches than people that don't. So that's kind of where that comes from. And then watching for acetaminophen toxicity. So the normal dosage, 400,000 a day. You may see 3,000 a day, where the manufacturer has said, we really think you shouldn't use more than 3,000, where the FDA has continued to say 4,000 or 4 grams is safe. Note that 1 gram is 1,000 milligrams, and these are in milligram dosages. But with an alcoholic or some patient that has terrible liver function, something like that, we might need to have the dose. And we really want to be careful for combination products. So maybe the patient's taking plain Tylenol, but then also taking some kind of cold and cough medicine that also has Tylenol, or some kind of severe pain relief like Vicodin that has Tylenol in it as well. So always watching out for the complete acetaminophen dosage. Always great to write out the dosages and the drugs in generic form. put them in the order. I like to put them in the same order each time so I can catch duplicates. But that's the review for exam 1. I hope it helps.